So, Bismillahirrahmanirrahim. So for GIT class, you see that GIT actually having GIT proper along with hepatology and nutrition. So we will try to do as much as possible GIT after GIT proper. Then the next class will be hepatology and nutrition. So this is the syllabus which is mentioned in the RCPCH. What could be the what things you have to know from the FOP and TAS. So just to see this. Then I want to mention you that something I make red, that means very important, and something I make that it's pink, that means you should read it, okay? And the red one means you will read these things for FOP, and the things which is mentioned green, that means it is important for the TAS exam, okay? For the TAS exam. But you know, the TAS exam having equal importance for the investigation and treatment, okay? It is both the things that is required for the FOP and TAS. So it is the way you have to read out this PDF file. So first of all, some questions could be in the embryology, which is not very much common, but it could be asked in the TAS exam. Okay, so we know that from the foregut, just 1 minute. So for the foregut, give rise to what are things like from pharynx to duodenum. We know from the midgut there is duodenum, small and proximal colon, and from the hindgut it gives rise to distal colon and rectum. So this is the things which never asked in the exam, but we just read it. TAS exam topic is there, okay? And GI tract is start to develop from 4th weeks and completed by 12 weeks. And we know from the endoderm, their epithelial lining is erased, and from the mesoderm, smooth muscle, ectoderm, nervous system, enteric nervous system is developed. So these are the things which is not very much important. But we have to give much importance on some disease. Among them, most important things is duodenal atresia. So if we come for the duodenal atresia, what is the most important things? Duodenal atresia, how present? Duodenal atresia present immediately after birth, usually immediately after birth with the vomiting. Okay, and it is the bile stain vomiting. Bile stain vomiting. So this is the after birth, they are presentation, but antenatally, if you go through the antenatally, they will present with polyhydramnios. Okay, and some syndrome are associated with this. It is the Down syndrome, it is the Prader, different syndromes, but most importantly, Down syndrome. Okay. So the questions will be like this. One child, after the first feed, develop bile stain vomiting. Child is Down score is high, so we know that Down syndrome is easily diagnosed antenatally by some ultrasound, okay, ultrasound findings and different way, but somehow they want to show you that it could be Down along with bile stain vomiting. So your diagnosis is duodenal atresia. This is the common way of FOP questions, okay? So after then, so it is mentioned here, but from here the task question is where the duodenal atresia commonly occurs. So where is the site? It is the site of ampulla of Vater. Okay, so you should know this, but never forget there would be antenatal presentation polyhydramnios along with ultrasound finding can show you antenatally double bubble sign, okay, on the ultrasound scan. It's also sometimes they mention jelly scan, okay. So the pregnancy profile scan, so in that time double bubble sign could be there. But when we go for the just 1 minute. So when we go for the after birth investigation, so it is very, very important, the chest X-ray abdomen. So we know that very neonate, when you do the X-ray abdomen, we will get specific findings. They will never ask you what is the X-ray findings, okay. But X-ray is also very important for diagnosis. Delayed presentation could be one recall question is related with this 6 or 7 day Bilus vomiting, Down syndrome, and there is no obstruction. In that times, we should know that sometimes duodenal stenosis could be sometimes present delayed, okay. Not always it could be the after first feeding. So some atypical presentation is there. So other than this, no questions from the duodenal atresia. And it is the things, you know, that if there is duodenal atresia, so how the food will be go through. There would be bowel stain vomiting. So never forget, after initial feed, when you get bowel stain vomiting, there could be down Prader-Willi, any syndrome. This is the diagnosis, okay. So very easy. Then there is something exomphalos and gastroschisis. It is not very much important, but some syndrome related things is sometimes came in the exam. So exomphalos is related with some syndromes, but what is these things? It is a midline defects. You see, it is a midline defects. So on the anteroabdominal wall, when the organ comes out, okay, through the abdominal cavity. So it is a exomphalos. It could be commonly associated with some syndrome like trisomy, Beckwith-Wiedemann syndrome, okay, or sometimes some cardiac anomalies could be associated. So exomphalos is something where abdominal cavity related problem, some organs could be comes out, and some syndromes could be associated, okay. And it will be covered by a membrane. You see some membrane is attached, a membranous sac surrounding it, okay. This is the exomphalos. If you have any things, you can interrupt me, no problem, you can ask me any questions, okay. Then if you go through the gastroschisis, it is something without membrane. You see, this is a gastroschisis pictures, and it is right hand side of the umbilicus. Right hand side of the umbilicus, you will get this, and here abdominal muscles are normal. This is the difference, okay. Usually not congenital anomalies are there and not covered with the membrane. So I say that it's not very much important, but syndrome related issues are there. You know, for the MRCPC exam, you have to know some syndromes, and sometimes exomphalos could be related with this. But another important things now we will read, that is the midgut malrotation. Okay, so malrotation, how could be present, and malrotation, what happened? Say common things, that malrotation is something which is like a normal rotation happen in the intrauterine life, and it is called 270-degree rotation. Okay, so with this rotation, GERD returns to the abdominal cavity. GERD goes into the abdominal cavity, but sometimes during organogenesis, this rotation could be hampered, and this times we call it malrotation. Okay, and malrotation is something which is related with bilious vomiting. Any child, if there is bilious vomiting, never ignored it, never ever ignored it. Bilious vomiting is very, very important. We should not ignore it. Any scenario, if they mention it, that is, it is like um 7 days, 8 days, 2 weeks. So bilious vomiting is there, but otherwise child is okay. You have to take it seriously. So bilious vomiting is a sign of malrotation. And we say this that when a child having malrotation, then they can be presented with bilious vomiting, or can be with the shock when there is something like gangrenous happen, or patient presented lately. Okay, septic features also there, with the malrotation. In that time you will get child having cold clammy skin and something like more severe features. And we know that sometimes after malrotation there could be twisting, and it is called volvulus. Okay, so in that time they will present to you like a severe finding or septic findings. So you will take it volvulus in that time when they present like this way. Okay, now how can you make your diagnosis? So initially we can do the X-ray abdomen, yeah, but it's not very much conclusive. It is not very much conclusive. Conclusive things is barium male. So every disease, one investigation you should know. For the duodenal atresia, I said X-ray abdomen, but here we will do also X-ray, but it is a special type of X-ray. It's called barium male. Okay, it is the diagnosis of choice. Okay, so what happened actually here? What you get? Like when you do the when you do the barium male, then you will think that your cecum will not be at the right side. It will goes into the left side. You will get some changes. Okay, and it can be left of the duodenum. Okay, duodenum, what happened? Duodenum normally lying right to the vertebral column instead of the left. So there is a task questions related this malrotation. Okay, so in that time when there is already malrotation, it's mentioned here, when there is a malrotation, then duodenum will be right of the vertebral column. Normally we know duodenum is on the left, but at that time duodenum will be right of the vertebral column. Okay, and this will happen, and also the cecum could be in the upper abdomen. It should not be upper abdomen. So if you get these things, we can think it is malrotation. So it is a question of TAS that is marked by the green. Okay, so now you will check of TAS. Pediatrics books is only for the TAS. Okay, it's a very elaborative books. So reading every line TAS for the TAS exam sub book is sometimes not possible for some persons. But if you can read, it's okay, good. But you can't remember everything. It is like nice to know. I read it before my exam. You can also read it, but it is like very far away. Before 3 to 4 months before exam you can read it, but shortcut way is the box. Okay, if you read the box it is enough. So this is the box I just attached here, all the boxes, important boxes. Okay, so just you see here what happened. A malrotation, a thriving 3-year-old boy vomiting from birth. Gastroesophageal reflux was diagnosed, but intermittent vomiting is occasional vomiting. A barium study was requested as an outpatient and was planned from a month later. Okay. But he was admitted in shock and was taken to the theater. So this actually, you see here a child having malrotation. So how can we understand that initially child was vomiting and gastroesophageal reflux was suspected, but then bilious vomiting started very child having barium study was requested, then child having shock with infection was diagnosed. He need major gut resection and child was maintaining on long-term parenteral nutrition for the 4 years. So they do not ask you any diagnosis because it is the task question. So they ask you which segment of the gut is most likely ischemic insert. Select one answer only. So don't see the answer options. Just read it and try to answer. So is it gastric body, duodenal intestine, proximal colon, and that the mid card and supplied by the superior mesenteric artery, or it is distal small intestine, proximal colon, as this originate from the mid card and supplied by the inferior mesenteric artery, or duodenum, small intestine, proximal colon, this originate from the mid card supplied by the superior mesenteric artery. Then the duodenal, small intestine, colon, this originate from hindgut supplied by the inferior superior mesenteric, none of the above. You can write it in your chat box. Okay, you can write it in your chat box. What could be the answer? Don't move your screen, just see. So we said it now that how could be the one answer only come, but what other said? So why not other things? You have to think by this way also. Like you see, colon cannot be a part of midgut, we know. So A is, we do not take A. B, why not B? Because you see here also they include proximal colon, so it is not the part of the midgut. And the D, they take duodenum as a part of hindgut, so we cannot say it. So that C is the right option because duodenum, small intestine, proximal colon originate from midgut and it is supplied by the superior mesenteric artery. Very right. Okay. I think you understand this is the way they ask you, and say that some books, these types of boxes are there. Some questions are even came in the exam, so it is not the questions which came in the exam before, but we should read out these things. Okay. So from the midgut, we know that distal intestine develop, and like after duodenum, and proximal colon also there, and they are supplied by the superior mesenteric artery. Okay, C is the right option. Yeah. Then the Michel's diverticulum. So the Michel's diverticulum, how they present, and what will be their normal presentation. We have to remember this. Michel's diverticulum main presentation is GI bleeding. Okay, lower gastrointestinal bleeding, lower gastrointestinal. Okay, this is their common presentation. Michel's diverticulum having lower gastrointestinal bleeding, and also they like parectal bleeding, some differential you have to remember. Whenever we completed all the scenarios, then you can make your diagnosis. But usually it's like when it's like a very small baby. Okay, and could have sometimes GI dyspepsia type of presentation also could be there along with bleeding. And how can we make our diagnosis? By the scan, okay, technetium 99M scan. So two things you have to remember here: lower gastrointestinal bleeding and scan. The diagnostic investigation. These two things only you have to read it, and there is no questions from here. But Hirschsprung's disease is very important, and many questions from here. Many questions. Okay. So from the Hirschsprung's disease, there is a very important question: is why Hirschsprung's disease? What is the main problem? What is the pathogenesis? This is a task questions which came many times. Okay, so we know that Hirschsprung's disease is a disease which is problem in the enteric nervous system. So ganglionic cell is absence. Okay, and if you go through in deep, why the ganglionic cell is absent? Due to failure of the migration of the neural crest. So some questions is like this: what is the Hirschsprung's disease is related with the neuroblast cell? Neurological problem. Okay, so problem, their migration is not completed, neural crest, failure of the migration of the neural crest, and ganglionic cells called aganglionic segments. Okay, so what happened? We know that enteric nervous system is another nervous system. It's called second nervous system. Okay, so our brain activates. Our brain is working. So when required, they wants to pass out. Okay, the excess materials in the gut. But as the ganglionic cell is absent, the child cannot pass out their stool normally. So main presentation of Hirschsprung's disease is constipation. Very severe constipation. This is the most important things. But Hirschsprung's disease, you know that its severity could be different or variable. Like it could be present absence of their cell, ganglionic cells, could be whole colon or small bowel could be. Okay, so very important things is Hirschsprung's disease. When you comes to know Hirschsprung's disease, you should know the history starts from birth. So this is like delayed passage of meconium. This is very characteristics of Hirschsprung's disease. Delayed passage of meconium. So if it is more than 72 hours. Okay, so if it is more than 72 hours. Okay. So delayed passage of meconium is very important for our exam. And after then, what will happen for the that is the constipation. Okay, childhood presentation is the constipation. So constipation will be very severe constipation, and along with there could be abdominal distension. Okay, abdominal distension. Okay, so abdominal distension, and as the child having constipation, there could be failure to thrive as well. Okay, so if you just get that delayed passage of meconium and very difficult child having failure to thrive, there is abdominal distension, then you will think of Hirschsprung's. But another things would be there. Another things would be there. That is the bilious vomiting also could be. So from the scenario, you have to make your diagnosis for Hirschsprung's or malrotation. So malrotation, constipation will be not predominant, but Hirschsprung's having constipation predominant. Okay, bilious vomiting could be malrotation and the Hirschsprung's both, But here, one important thing is delayed passage of meconium and severe constipation. Okay, if it is mentioned, that is okay, but abdominal distension, for the malrotation also possible. And also failure to thrive for the Hirschsprungs. It's not an acute condition. Okay, now very important things is how can you confirm your diagnosis? How can you confirm for Hirschsprung's disease? It is the suction biopsy, very specific. You should know it, suction biopsy, to confirm your, like what happened, absence of the ganglionic cell. Okay, absence of ganglionic cells. You will confirm this from suction biopsy. And when you understand that it is Hirschsprung's disease, you have to refer to which specialist. Always, it is very important to know the specialist, where you have to refer. Which specialist? Pediatric surgeon. It's very, very important. Pediatric surgeon. This is the most important things. So Hirschsprung's is important for the exam, but you will not get anything written in the pediatric guideline for the Hirschsprung's or malrotation or duodenal atresia. But many questions there, okay? Some cases are related to this. I will discuss the FOP case book, but it is not discussed in the pediatric guideline thoroughly, okay? But you will, if you go through the pediatric guideline, which is applicable for 2024, I will upload all the books in the groups, okay, different group. But pediatric guideline, you have to go through the GIT chapters, and there you will check something is written, you will read these things, okay. So anything you want to say? I just check chat. Nothing is mentioned here. Okay. Then anorectal anomalies. There is 1 to 2 questions related to the anorectal anomalies. We know that is something where problem in the caudal end of the GIT tract. Okay. Not properly developed. So when there is anorectal anomalies, always we think of bacterial association. Okay, and other anomalies could be there. So it is a things, but anorectal anomalies is there or not, it is could be diagnosed neonatal examination. So it is some very, very important neonatal examination. We have to make our diagnosis, and it is mentioned in the neonatal guideline. There are some pictures also there, how it looks like anorectal anomalies if there. So it is said that it could be like you can sometimes you cannot make your diagnosis in the boys, okay, but missing ARM anorectal anomalies, malformation in a girl is usually break of duty. So it is a very serious thing if you missed it during neonatal examination. And it is also mentioned that if you are checking a neonate and some meconium is already passed, it doesn't mean that child is out of ARM, out of anorectal anomalies. You have to take it. Sometimes child with malformation, anorectal malformation, can pass meconium through a fistula. Okay, still anorectal anomalies is something you have to refer pediatric surgical team. You have to keep your child NPO, because at the neonatal time there could be some problem related with this. Okay, need surgery, depends how severe their presentation. But from here, just I want to tell you that for the FOP exam, TAS exam, you have to remember these things, nothing else. Okay. Now we will read very, very important things. So actually I said duodenal atresia, Hirschsprung's disease. Now we'll read the intersusception and other things very important. So take a deep breath before that. Are you with me? Any problem, anything you want to make clear? Okay, if it is not, then we can proceed. Okay. So intersusception is something we know it is like invagination of one portion of the our gut into the another portion. So it is called intersusception. It is nicely explained telescoping of one segment of the bowel to the another segment. For someone said that some example, what is this? For which, please can you give some example for this? For which intersusception or anorectal anomalies or others? Write it. I don't get your point, Dr. Nayab. Nayab, yeah. Okay, write it again. So what I say that intersusception is telescoping. Okay, so this is a task question. What does it means? It's happened after upper respiratory infection, and I can write it. I think intersusception is very important. So if I write, then you can give more concentration, that I believe. So intersusception, okay. Intersusception is something, it is a so Dr. Nayab, remain with me. I will discuss a case, then you can understand how the question is, and I can also understand how you receive my talk. Okay. So just remember these things. Intersusception is I said already, it is a telescopic and like one portion is invaginated to another portion of the gut. It is that intersusception, and it's present after upper respiratory infection sometimes, and it is their normal presentation is 2 months to 2 years. Okay, 2 months to 2 years. So it is something very early presentation. Huh? Another things is there would have recurrent abdominal pain, and the abdominal pain is very characteristic. In between time, initially a child will be okay. Initially, child will be okay in between the abdominal pain, but it would be recurrent abdominal pain and severe. It would be severe. After then, when the abdominal pain will be increase, in that times, in between child will not be okay. Child become lethargic with the time. Child become lethargic. And another things, child will be look pale. So this look pale is doesn't mean CBC will be low hemoglobin. No, child hemoglobin will not low, but child looks pale. Okay, that is different issue. So child having severe pain, and it's like they have been consonable crying, drawing up the legs, along with vomiting could be there, diarrhea could be there, but very important things is parectal bleeding. So I said now one time another disease related with parectal bleeding. Which is the disease? Who can say? Could be present with lower gastrointestinal bleeding, with the intersusception could be a presentation. Can anyone mention me?
Meckel's diverticulum.
Meckel's diverticulum. Yeah. So it is Meckel's diverticulum, also presented with parectal bleeding, or could be associated with Hirschsprung's disease. Yes, intersusception. So intersusception. Okay. So intersusception, another very important things is parectal bleeding. Rectal polyp also could be parectal, but when we think about the intersusception, closely related this this Meckel's diverticulum with the intersusception. Okay, then another things we can get, that is a mass in the abdomen. It's not fish, it is a one type of sausage shaped mass. It's called, it crosses the midline, and it could be in the right upper quadrant. Okay, could be in the epigastrium behind the umbilicus, could be palpable. Okay, and yes, but one important thing is, when the child is present more than 2 years, we have to think it could be the different cause. It could not be like a simple invagination. It could be related with the Meckel's diverticulum. It could be related with the polyp. It could be related with the lymphoma. Even it could be HSP. Okay. Could be cystic fibrosis as well. So it could what we discuss among them, most important things, which is called triad. We have to remember these things, triad. Sometimes we become confused with the intersusception, along with, even we can confuse with the HUS, because some questions are like this, HUS related questions. So child having bloody diarrhea, and child looks pale. So in case of hemolytic uremic syndrome, also you can get bloody diarrhea, followed by child will be pale, their renal function will be impaired. Okay, but here HSP having bloody diarrhea, which is not actually diarrhea. Sometimes it part rectal bleeding, they mention like a bloody diarrhea. Okay, so it is called red currant jelly stool. It is a red currant jelly stool is a one of the triad. And then another triad is recurrent abdominal pain and abdominal mass. These are the triad. Remember this: red currant jelly, abdominal pain, abdominal mass. But what I said, that how can you differentiate with the HUS? Very important things here. You do not get any child having hemoglobin low. No, child hemoglobin will be normal, usually not low. Okay, so how can we make our diagnosis of the intersusception? Ultrasound scan. Ultrasound scan is the diagnosis of investigation. Here we can say Duffnut sign. Okay, Duffnut sign. Hyperechoic, hypoechoic, outside hyperechoic. It's not important. Just remember that intersusception ultrasound you have to choose. So many questions, like you have to know the one investigation. So if I just recapitulate our previous materials, that is malrotation. So malrotation is one investigation. Barium meal. If say choose then I say Meckel's diverticulum. Hirschsprung's to suction biopsy. If I said an intersusception, you will choose a sound. Okay. It's surgical. So special is very, when there is small history, like okay, sorry for the interruption. Just let me know. I hope now it is okay. My voice is all right. So I just said about treatment. That means you have to do the surgical consultation, along with you have to go for bowel reduction. That means you have to remove the portion which is invaginated into the another portions. Okay. So how can you do this? You can do by hydrostatic reduction or pneumatic reduction. Nowadays, pneumatic reduction is not there. Hydrostatic reduction is a good option. Okay, but there is chance of perforation. And also, if it is not successful in that cases, or if child comes to you very lately, you have to go for open surgery. That means you will open the gut and you will remove one portion from another portion. Okay. So I think treatment portion very elaborately you do not have to know, just you should know about what could be the option. Bowel reduction is one option, hydrostatic reduction, another is open surgery. Okay, so after then we have to know about esophageal atresia, tracheoesophageal fistula, but I want to discuss with one case. Okay. So, just three, here it is, you see, it is chapter 37. That means it is FOP case 37. Okay, it is FOP case. So where is the answer? Answer in the FOP case 37. So you will open the FOP case 37, then you will get the answer. But here I will want to know from you. I want to clear it, okay? So it is related with this question. So I just want to go for this question. Okay. So a 16 months, you have to answer these questions, okay, everyone. A 16 months old girl present with a history of melena for the last few days. His mother's... Okay, just 1 minute. It's now okay. His mother say she seems to have tummy pain in the morning, but better when she has eaten. So this tummy pain become okay after feed. She fractured her leg 2 weeks ago when she fell down, and she stares and her leg remain in a plaster cast. She is otherwise well. His mother has given her medicine to help with the pain. But problem is melena for the last few days. So parectal bleeding, one type of. So we know that melena is altered blood, passing of altered blood through the parectally. So with this stool, okay, so it is some altered blood. But problem is here they give you that child having tummy pain and child having history of fall. For that child is taking some medicine to reduce the pain. Okay, plaster cast was given. So this is one scenario. Then another scenario is 14 months old girl present with 10-hour history of screamings, now having non-bilous vomiting, 14 months, okay, had passed a red mucus stool. He's normally fit, well through, had a cough and cold in the last week. Cough and cold, hand passing red mucoid stool, and there is non-bilous vomiting. Patient child having screaming, is screaming. She's normally fit, okay. On examination, alert, pink, well perfused, but lethargic. Her abdomen is soft, non-tender, with a mass in the right upper quadrant. So here, what you get? Second scenario. Okay. If I just put you, first scenario, child having melena, right upper abdominal pain. Second scenario, we get child having abdominal pain, having a red mucoid stool, okay, also with vomiting, some diarrhea also, history of upper respiratory infection, and there is a mass in the abdomen. Okay, first and second scenario. Okay. After then, we will read the third scenario. Okay, a 15 months old boy present after his father found his nappy full of bright red blood. His father says he has been well, playing normally all day, no past medical history of note. On assessment, he is pale. His capillary refilling time is prolonged. Heart rate is 180. Is it appropriate for 15 months? No. Tachycardia. Tachycardia, prolonged capillary refilling time, pale. Respiratory rate is 40. Blood pressure 70/50. Saturation okay. Chest clear, heart sound normal, pulse weak, abdomen soft, non-tender with no palpable mass, no mass. So 15 boy, there is parectal bleeding and these types of presentation. What do you think? For third scenario. Okay, so many of you said for the second intersusception, someone said first one is, I have to check what said you for the first one. Upper GIT bleeding, any side induced. Okay, I can take it, any side induced upper GIT bleeding. And the third scenario, okay. So third scenario related some confusion you have, I can see. Okay. Different persons say differently. So just we can summarize the third scenario, then it will be more easy for you. If you just see here, you will get some shock features now. Shock features, okay. Along with what other things? What was there? It is 15 months. There is no mass, but shock features, and there is parectal bleeding. Yes, so I said shock. Okay. Just I have to remove this. Just 1 minute. Okay, so how can we make our diagnosis for the first scenario? Actually, it is something related with the peptic ulcer disease. Okay, something related with the peptic ulcer disease. And second one is intersusception. So you have to choose, just you have to give your diagnosis here. So intersusception is your diagnosis. You have to do the ultrasound. And then third one is Meckel's diverticulum. Meckel diverticulum can be presented like a here no option. You see here I do not give any options because here most important things is to make a diagnosis. Okay, so here most important things it is Meckel's diverticulum playing could be like this way: parectal bleeding, shock features, and you have to do the Meckel scan, okay, to reach a diagnosis. Okay. So I think now you understand that different way of presentation could be there, but what you have to do, you have to read the FOP TAS case, okay. There are many questions with the recall papers, so you have to go through the recall paper as well, okay. Just 1 minute. So I think you understand that how the intersusception is, how the upper GIT bleeding could be melena, okay, related with the taking of that is NSAIDs, and against Meckel's diverticulum could be, okay. Volvulus you said, but against the volvulus, which point? They said in the question, they said that there is no bilious vomiting. Abdomen is soft, non-tender. So how can you think that it is this is like volvulus or malrotation when abdomen is soft, non-tender, and no bilious vomiting, okay? And when there is no palpable mass, we do not think of intersusception. So only there is parectal bleeding and there is shock features. What other diagnosis you said? I have to check. Yes, Dr. Tahra Alali, you said Meckel's. It is very right. Meckel's, also Dr. Aisha Tasneem, you said, but it cannot put volvulus. Why I said? Hafsa Afzal, intersusception, you said. Okay, right. Okay, thank you for your answer. Now another important things we can go, but if you are become like weak with a continuous hearing is not easy task, so we can make some gap, or I can just continue. Today we give 45 minutes or 1 hour for the introduction, but it's very important for the beginner, okay. Okay, so let us start the tracheoesophageal fistula. Then if it is required, anyone here wants to make any any gap, please let me know. Which book? It is okay, so just after tracheoesophageal fistula, we'll make a 5 minutes gap, okay? But it is everything is not in the book, okay? But the things I show you, the questions is in the case book. It's mentioned, the case book, okay, 37. You have to FOP case book, okay? So it is not like one book or from one side. It's something I just make from the very, I should say, reliable. That is the case book, pediatric guidelines. Sometimes it is required. Then NHS guideline, NICE guideline. Okay, the textbook of pediatrics that is called Sunflower Books, Science of Pediatrics book, sub book. So it's not, I cannot mention only one book, okay. Okay, so just read esophageal atresia, tracheoesophageal fistula. It is like It is something which is, we know that tracheoesophageal fistula is a congenital anomaly disorder. So here, is it possible antenatally diagnosis? Yes, possible with the polyhydramnios. Okay, with the polyhydramnios. So it is the polyhydramnios which could be there. So any child with polyhydramnios, then there is duodenal atresia as well. Remember these things. Then after birth, what will be their typical presentation? Typical presentation is feeding difficulties. So feeding difficulties, if there, then remember, there are some differentials with the feeding difficulties. Okay, so what could be? We know that if there is cleft palate, then could be feeding difficulties. So cleft palate could be associated with the syndrome, DiGeorge, Church syndrome. Okay, so some syndromic association could be there. What other things? Down syndrome could be a feeding problem. There could be what other things? Prader-Willi syndrome could have feeding problem. So I just say you that after birth there is feeding difficulties. Tracheoesophageal fistula is a very important diagnosis, tracheoesophageal fistula, but these could be associated with feeding difficulties, down, Prader-Willi, cleft palate, other syndromes, even choanal atresia, choanal atresia, it's a very important thing. Choanal atresia could be unilateral or bilateral. Unilateral present with feeding difficulties, but bilateral having special characteristics. When there is choanal atresia bilateral, so what could be? They will, when they cry, cyanosis disappear. This is a question in the for the exam. Cyanosis disappear when the cry. Bilateral tracheoesophageal fistula. Cyanosis disappear. But when they don't cry, cyanosis appear because they are nasal orifice, bilateral. So choanal atresia, oxygen cannot enter. When they cry, then oxygen enters. And bilateral choanal atresia related to the Church syndrome. Church. Okay, congenital heart disease, anal problem, genital problem, tracheoesophageal fistula could be renal problem. So many things could be related with the Church syndrome. Now, esophageal atresia and other things, they could have respiratory distress, shocking, cyanosis with feeding, so feeding related issue, and frothing at the mouth. Okay, and it present few hours of birth. And other things, diaphragmatic hernia. Diaphragmatic hernia also same presentation, like feeding problem, distress, choking, frothing at the mouth. But diaphragmatic hernia we will get when we take our stetho, then the bowel sound will be at the chest. Okay, and scaphoid abdomen will be there. Okay, so some difference you should understand, or you should know it. So there is a questions in the TAS exam that which is most common type of tracheoesophageal fistula. So tracheoesophageal fistula is sometimes A type, B type, C type, D. So most common is C type. Okay, so it is like atresia and distal fistula. So without any fistula, if there is no fistula, only there is esophagus blinded. So what happened if you have these types of problem? They are severe presentation. Okay, and most importantly, when you are confused, child having choking, feeding problem, you will introduce NG tube. Then NG tube will not go past way. It's not possible. So it curled. Okay, so after then you will do X-ray. and you can confirm that this is tracheoesophageal fistula because NG tube curled round. Okay. Other than this, it is the most important things. Confirmation by radiography and management is by surgical correction. Different syndrome could be there. Just read out these things. Okay, so we will take just 5 minutes, only 5 minutes gap. Then we will come back. Okay. So you will read the recall paper, case book related to the FOP case task, which is mentioned here. And also you will read after this class, okay, pediatric guideline, okay. Now, Freya is a full-term baby girl with a birth weight of 2.588, so 2.5 kilo, who was discharged from the midwifery-led maternity unit at 6 hours of age. She was thought to be well and stable at discharge. She was brought to the emergency department by her mother, 15 hours of age, with breathing difficulties. So here quotient is child having breathing difficulties at 15 hours of age. Okay. His mother says that she has been choking when she was tried to feed her on 4th occasion. So child having feeding difficulties, choking happened. She was born at term by normal delivery, Caucasian mother, type 1 diabetes. So who has type 1 diabetes? 20 weeks anomaly scan shows normal fetal anomaly. So there was no problem that time. During the pregnancy, mother was drunk 3 to 4 units of alcohol and measured large for deaths on PYC symphyseal fundal height. So child having large for death, it seems to be during the pregnancy time. Okay. And she presented with reduced fetal movement 2 occasions at 36 weeks, but reassurance cardiotopographic monitoring. Okay, there is reduced fetal movement, but CTG was okay. So it's not important. On examination, Freya is pink. So Freya is pink, well perfused, temperature was normal, heart rate okay, respiratory rate is 72, it's very high. Heart rate slightly increased, oxygen saturation was okay, some frothing at the mouth, and she has marked subcostal intercostal recession. Air entry is equal bilateral, no added sound. So we can say that it is not like a pneumonia or sepsis. There is no respiratory problem, like child breathing sound is normal, but there is distress, respiratory distress without any respiratory component problem. So it could be other than respiratory cause. Problem is the feeding. Okay. Heart sound normal, femoral pulse, so there is no cardiac issue there, no hepatosplenomegaly, there is no sepsis, good tone, good suck. NG tube was 16, nurse passes NG tube 16 centimeter of obtains obvious clear secretion. Okay, so NG tube is not the actual site. So what is the features in mother pregnancy most indicative of underlying diagnosis? You are thinking something like you have some diagnosis, but which is mostly related to your diagnosis. Alcohol, is it fetal alcohol syndrome? Why alcohol intake is we will take. So it is one thing. Another thing is large for dates. Fundal height, normal fetal scan, there is reduced fetal movement, type 1 diabetes mellitus. So what we will think, it is tracked on many persons with say very good ways. Dr. Aisha, Dr. Jamin, Dr. Aisha Tasnim, Nure, Dr. Nayab. Yes, it is indicative of polyhydramnios because fundal height is larger. Which investigation? So B is the right answer. 1B is the right answer. Yes. Then which investigation is most likely demonstrate the underlying diagnosis? So tracheoesophageal fistula is your diagnosis. How can you investigation? How you want to do the investigation? I said already, which is the important investigation to make your diagnosis. So you cannot make your diagnosis if you just do the abdominal X-ray, abdominal ultrasound. You have to do the chest X-ray. Yeah, chest X-ray, you will see that your NG tube is curled, okay, like C-shaped. Now, what investigation is needed pre-operatively? Echo, limb X-ray, renal ultrasound, serum cortisol, spinal ultrasound. So investigation, something is related with the your operation. Okay, some operation will be done, pediatric surgeon will be do, but here you have to know before operation what investigation is very, very important or most important. We know that we have to do all the things, ultrasound, renal ultrasound we have to do because bacterial association could be there. But here we take echocardiography. Yes, echocardiography. Who said A is the very right? Why? Because they could have some cardiac problem. Okay, although we say that they are on cardiac evaluation, there is no problem, but we have to do the echocardiography to confirm it with the tracheoesophageal fistula. There could be some cardiac issue, so you have to do the echocardiography. So you have to confirm it that cardiac issue is there. If child having some limb problem, like there is some limb issue there, but it is not directly associated with your operation, okay, it will not hamper your operation. You take your child under anesthesia, you have to be very much confirmed that there is no cardiac issue there, because in that cases your anesthetic protocol would be different. Okay, so limb X-ray, ultrasound scan, anything you can do, but like if you want to know the other association, but pre-operatively, which is most important, echo. So this is the question type which is called best answer question. Okay, here you have to choose one. There is probability of every answer to be right, but which is the most right, you have to take it. This is the question way. Okay, I think tracheoesophageal fistula we have covered. That I see that question tracheoesophageal fistula task related some questions, which is more questions with the task related. Okay, all over the GIT. But diagnosis is, I think, more or less, it is easy. So like tracheoesophageal fistula, why happen, which type, which is more common, okay, which type is delayed presented, H type of fistula is delayed presentation is there. Okay, and another things, how can you make your diagnosis, X-ray, choking, feeding difficulties after birth, this could be there. So I think you understand, this is the basic things. Then hypertrophic pyloric stenosis. It is another diagnosis which is very important and we have to know it. So it is something, which is, it's called polygenic. Polygenic means genetic association with other influence. So genetics could be there. So genetically susceptible persons with environmental influence also could be a cause. So it is a task question, genetic and familial disorder. But what happened with infantile hypertrophic pyloric stenosis? Pylorus will be thickened. Pylorus will be thickened and its pyloric lumen cause obstruction. Okay, So here problem is vomiting. So what is the problem here? Vomiting. But it would be bilious or not bilious? Non-bilious. What other things? Here this vomiting is, which is reached distant site, but it's not from very beginning, not always, okay? It projects into the distant side. And after vomiting, child will be hungry and constipation could be there. Okay, after vomiting, any child, usually this is 2 to 6 weeks. Remember, this is 2 to 6 weeks of age. So at this age, we can get the child having vomiting as well. We can get child having normal vomiting, positive, okay? So at this age, but after that, is they become hungry? No, never. When it is benign, we know that sometimes child having gastroesophageal reflux, for this they vomit, they have fasting. So after each feeding, they vomit out, but child will be okay. They have no weight loss, they have no dehydration, they will not feel hungry. So it's a very important sign from benign to non-benign. Okay. Another important thing is with the hungry, they could have failure to thrive because child is eating and vomit out. They cannot take nutrition. Okay, so failure to thrive is there. Along with examination findings is visible peristalsis with mass. So this mass is like pyloric mass. We read intersusception having epigastrium mass. Okay, we have to give the child some water and to see is there any mass there or not. Okay. So this is the clinical presentation. When you confirm or when you clinically suspect your child could be IHFPS, infantile hypertrophic pyloric stenosis, you have to do some investigation, and the investigation of choice is ultrasound, which is the confirmatory, and they will say that yes, IHPS is there. But before that, most important investigation is urea electrolytes. So mainly electrolytes. What you will get? Tell me. It's very important that we know from very early of our study. Okay. So is there anything change in the potassium? Yes, it is hyponatremia. Sorry, hypokalemia. Okay. So it is hypokalemia. It is hypochloremia. It is hypokalemia, hypochloremia, and metabolic alkalosis. Okay, metabolic alkalosis. So that means bicarbonate will be high. This is the most important electrolytes abnormalities. And one, I should say that one awkward question is that is repeatedly came in the exam. Which is more important, hypokalemia or hypochloremia? So we research on this and we get that fluoride is more important than potassium. Why? Because sometimes potassium level could be normal as well. Okay, and metabolic alkalosis could be sometimes paradoxical aciduria as well. So hypochloremia is more important. So question was, which is more important, hypokalemia or hypochloremia? We will take hypochloremia. This is a repeated question. So after that, how you manage a case of hypertrophic pyloric stenosis? So you see that your child having vomiting, projectile vomiting, and child could have dehydration. So what you will do, your first task is to dehydration. So dehydration correction is most important things. And electrolyte imbalance correction. So you do not go for surgery now until your potassium correction is corrected or metabolic alkalosis is become normal. So what most important things to give correction. And we know potassium is very crucial for our body. And then you have to refer to the surgical department, and you should know that they will do an operation which is known as Ramstead pyloromyotomy. Okay. So it is something like they will split the muscles, and then yes, they split the muscles. Okay, hypertrophic muscles. So this is the infantile hypertrophic pyloric myotomy. So nothing to be worried with this. You know how is their presentation. Okay, I think we will read one case is related with this at the end. When we read the vomiting, we will go through these things. Here just I want to clear you another things, that hypertrophic pyloric stenosis, I said polygenic inheritance. So it is something like genetic influence is there, but more common on the male. But if you consider that if any woman suffered from hypertrophic pyloric stenosis, okay, women suffered from hypertrophic pyloric stenosis in childhood, although male will be more sufferer, according to our statistics, more male child is sufferer, but if female child sufferer, then they have high chance to give birth a child with hypertrophic pyloric stenosis. Okay, so give birth a male who have infantile hypertrophic pyloric stenosis. There is a sub case related with this. It is it's a very much famous things which is called Carter effects. Okay, so if we read it will be more clear. 6 weeks old boy present to the emergency department with 1 week history of vomiting. Okay, parents report that vomiting has get much worse over the last 2 days, and the child is now hungry and unsettled. Only 6 weeks. His older sister, who is now 5 years old, had pyloric stenosis when they have infant. When they have infant, but neither parents had the condition themselves. A 10 years old brother is unaffected. Okay, on examination have visible peristalsis, a slow muscular contracture, 3 per minute on the stomach, visible in the upper part of the abdomen, and ultrasound scan confirm pyloric stenosis. So from here you will see the scenario as well. Not only this give you the diagnosis, but you should see that how they present. Okay, vomiting, unsettled, hungry, and there is a family history also here. So they want to say that older sister having at 5 years old was diagnosis like this. Okay, but brother is unaffected. So maybe three siblings. So visible peristalsis also there on the upper part of the abdomen. Okay. So concerning the heritability of pyloric stenosis, assuming random mating on the future, which family member is most likely conceive a child with pyloric stenosis in future pregnancy? We will give birth a future we will give birth a child with pyloric stenosis. The infant itself, boy, or infant father, or infant mother, or the older brother, or older sister. already I said Carter effect. So older sister having more chance. It is discussed in the Science of Pediatrics books, never asked in the exam. If you see the exam way, never asked, but nothing to be worried. We know the Carter effects means if any female child having any history of infantile hypertrophic pallid stenosis, they have higher chance to give birth in future pregnancy. Okay, so it is called Carter effect. Some persons called Carter uh, invented these things. So after then, just go for something you have to write. What is the mucous next cell secreted, chief cell, G cell, parietal cell, D cell, enterochromaffin cell, many questions with this. Okay, where the absorption occur, where the secretion occur. So after then, celiac disease is there and many things are there. But I think today we concluded here, and then in the next class we'll read the hepatology nutrition along with the rest part of this disease, that is celiac. Because today is our first class, so if we I think we just take some times. Okay, already 2.5 hours we passed out. But most important things we read now: vomiting, abdominal pain, constipation, that is related some pediatric guideline. We will read these things: vomiting, abdominal pain, and gastroesophageal reflux. IBD is there, and celiac disease is very important because celiac is a disease of the white persons. Okay, so Caucasians. So you have to read all the things related with the Caucasian. Okay, whatever. I think it is useful for those who are just with me for the last 2.5 hours. So let me know, guys, how you feel with this class and how you become benefited with this. And next class we will continue these things. If you have any query, let me know. I said that how you have to read out. Okay. Thank you, Dr. Aisha Tasneem. Okay. Okay, inshallah, we will meet again. Thank you, all of you. But, you know, how to read. Okay, you know how to read, and you have to read by this way. Okay, without it, it is like if you don't go through, if you don't utilize your benefit that you get, I will not be successful. So read out by this way, and all of you who join my class, you should read the case book, you should read the pediatric guideline, you should read the things like when you get any difficulties, you can go through the NHS side, NICE guideline, so to make your conception clear. And there are a lot of recall papers, so you have to read it. I will share the books needed for all the groups. Okay, I will share the books needed and also the recall papers so that you can make yourself prepare as well. Okay, and feel free to contact me whenever anything required. As much as I will try to help. Okay, everyone have some limitation, you know. So if it is not given my limitation, I will try to help out. Thank you, everyone. Assalamu alaikum wa rahmatullah. Good night.